Chapter 21, Treatment of Gastroesophageal Reflux Disease, Laryngopharyngeal Reflux, and Peptic Ulcer Disease. Gastroesophageal reflux, GER, is a condition where the stomach contents flow up into the esophagus, producing symptoms described as heartburn. Persistent GER more than twice a week is a sign of GERD. It is estimated that 20% of Americans have GERD, and they may initially produce minor discomfort such as heartburn and chronic cough. Excessive or chronic exposure to gastric acid and pepsid may produce inflammation, ulceration, or hemorrhage, and changes to the epithelial cells that can lead to esophageal or stomach cancer. Any age group can develop GERD. Infants may have GERD because their digestive system is immature. However, many will outgrow it by their first birthday. Obesity, smoking, and pregnancy are additional risk factors. GERD is a motility disorder associated with impaired peristalsis. Peristalsis is a forceful wave of contractions in the esophagus that moves food and other orally ingested contents from the mouth to the stomach. The lower esophageal sphincter is a muscle located at the junction between the esophagus and upper stomach that relaxes to permit food and liquids to pass from the esophagus into the stomach, and then contracts to prevent stomach contents from returning to the esophagus. So A shows where figure 21.1, A shows the location of the lower esophageal sphincter. So this is the esophagus, and when you eat food, it obviously travels down your esophagus and it needs to make its way into the stomach, which is right here. But we have a sphincter that's right here that closes and opens as needed when you're eating. And it should stay closed after you're done eating, so no stomach acid makes its way back up to the esophagus. Many factors can aggravate GERD. These include foods, lifestyle, prescription and over-the-counter medications, and even body positions. GERD symptoms are made worse when the body is in prone position, lying down. Raising the head of the bed 6 to 8 inches can reduce symptoms. Pregnancy and obesity can also aggravate GERD. Many prescription and OTC medications can also worsen GERD. These drugs impair peristalsis, delaying gastric emptying, decrease esophageal sphincter tone, and decrease the protective mucosal lining and or increase gastric acid levels. So table 21.1 lists natural alternatives for gastroesophageal reflux disease. So we have all these different categories of safe foods and foods to avoid, and then the natural alternative. Next, 21.1 lists prescription medications that worsen gastroesophageal reflux disease. So anticholinergics, opioids, calcium channel blockers, NSAIDs, hormones, benzodiazepines, iron supplements, potassium supplements, and many more. Laryngopharyngeal reflux is closely related to GERD and can occur simultaneously when gastric contents reflux into the larynx and pharynx located in the head and neck region. Inflammation occurs that may cause hoarseness, voice fatigue, laryngitis, sore throat, chronic cough, bad breath, sinusitis, wheezing, aggravation of asthma, and even middle ear infections. As in GERD, LPR occurs when the normal reflux barriers fail. Anatomic barriers that protect against LPR are the gastroesophageal junction, which includes the LES, and the upper esophageal sphincter. The UES separates the pharynx and the esophagus. It relaxes to permit the passage of foods and liquids during swallowing, preventing air from entering the esophagus during breathing, and prevent gastric secretions entering the pharynx via the esophagus. If the UES is damaged by exposure to stomach contents, it can become less sensitive and lose its ability to function properly. This increases the likelihood of reflux and more damage. Laryngeal mucosal resistance protects the larynx from damage caused by reflux. An ulcer is an open wound or sore. Ulcers can occur anywhere in the body. In the gastrointestinal tract, gastric ulcers form in the stomach. Duodenal ulcers form in the upper region of the small intestines. And peptic ulcers form in the duodenum. H. pylori infection is the primary cause of peptic ulcer disease. Infections are transmitted person to person by the gastric oral route. Once the bacteria are ingested, they release buffers that enable the bacteria to survive in the acidic contents of the stomach. The bacteria also releases virulence factors that are responsible for inflammation and tissue damage. Fortunately, most people who are affected with H. pylori will not develop chronic gastritis or PUD. An endoscopy may be performed to look for ulcers inside the stomach and small intestine using an endoscope, a thin, flexible tube with a small video camera and light attached to one end that is passed down the esophagus into the stomach. So table 21.2 lists the different symptoms between gastroesophageal reflux disease and laryngopharyngeal reflux disease, and then peptic ulcer disease. Lifestyle changes to reduce the risk for GERD and PUD or their symptoms include eating small, frequent meals, avoiding foods that aggravate GERD and PUD, limiting alcohol consumption, and stopping smoking. Cigarette smoking interferes with the healing of an ulcer by constricting blood vessels in the ulcerated area. Alcohol is also a gastric irritant. So we have these lifestyle modifications that are recommended, which we just talked about. Drugs used in the treatment of PUD, GERD, and LPR are classified according to their pharmacological effects. 1, acid suppressing drugs. 2, mucosal protectants. 3, prokinetic drugs. 4, acid neutralizing drugs. And 5, drugs that eliminate H. pylori. It is a myth that stress and spicy foods can cause ulcers. However, some foods can aggravate existing GERD. And a common ending for these H2 blockers that we're going to talk about is tadine. So there are 4 receptor antagonists marketed in the US, but this book is a little bit outdated because we have cimetidine, famotidine, and nizatidine, but ranitidine has been removed from the market. All H2 receptor antagonists are available in prescription and non-prescription strength. And then we have our list here. So you can see all of them have a lot of different dosage formulations. And then we have a combination Pepcid Complete, which is over the counter. It has Pepcid, the famotidine, but it also has calcium carbonate and magnesium hydroxide. There are 6 PPIs currently marketed in the United States: dexlansoprazole, esomeprazole, lansoprazole, omeprazole, pantoprazole, and rabeprazole. Esomeprazole is an S isomer of omeprazole, so it's a mirror image. Omeprazole and lansoprazole are available for OTC use in the United States. And actually, esomeprazole is also available over the counter now. OTC PPIs are marketed for the treatment of heartburn. And what that means is if you actually go to the store and look at omeprazole, which is the generic for Prilosec. So if you find Prilosec or the generic, it'll say on the back that you shouldn't take it for more than like 2 or 3 weeks without consulting your doctor. And that's just because you probably have something else going on. But if your doctor prescribes these to you, you probably will take it longer than that because you're being treated for GERD more than likely, not just for heartburn. It's important to note that these drugs taking them will not just make the heartburn go away in an acute way. So if you're having heartburn, you wouldn't take one of these to relieve it because these take some time to work. So you would take an H2 receptor blocker here, and those would work immediately. Well, not immediately, but way quicker than the other one. All right, so we have our chart with proton pump inhibitors. So lansoprazole is only available as a capsule, but esomeprazole is available as capsules, powder for suspension, powder for injection, and a delayed release tablet. Lansoprazole is available as a disintegrating tablet and a delayed release capsule. Omeprazole is formulated in capsules, granules, tablets, and disintegrating tablets. Pantoprazole has granules for oral suspension, powder for injection, tablets, and enteric-coated tablets. Then we have more PPI combination products. So Vimovo is esomeprazole plus naproxen. So it has a NSAID in it with a PPI. Lansoprazole, amoxicillin, and clarithromycin. Those come in a combo pack, usually for H. pylori. And Zagradid OTC, because it is available over the counter, is omeprazole and sodium bicarbonate. Misoprostol and sucralfate are mucosal protectants. The drugs protect the epithelial cells that line the stomach and small intestine from damage by gastric acids, pepsid, and H. pylori. The drug is approved for the prevention of NSAID-induced peptic ulcers. Sucralfate is approved for the treatment of maintenance therapy for duodenal ulcers. Misoprostol is a synthetic prostaglandin E. It stimulates the production of protective mucus and bicarbonate in the stomach. It also increases the regeneration of gastric epithelial cells and enhances blood flow to the stomach. Sucralfate binds to the ulcerated area and forms a protective barrier, much like a bandage protects a sore. That's important to remember. It also promotes the regeneration of stomach epithelial cells. It is a weak inhibitor of H. pylori. Misoprostol is labeled with a box warning that the drug should not be taken by pregnant women because the drug may stimulate uterine contractions. So misoprostol is only available in tablet, but sucralfate is available as an oral suspension and a tablet. Prokinetic drugs are used for the treatment of GERD and LPR. They increase peristalsis, speed up gastric emptying, and improve LES tone. Metoclopramide is currently the only prokinetic drug approved by the U.S. Food and Drug Administration. So when a drug tends to be the only one, that's a good indication that you might see questions about it on the PTCB. So this one down here is not available in the US, so this is the only one we have. It comes in an orally disintegrating tablet, a tablet, ejection solution, and an oral solution. Antacids are the oldest drugs used for the treatment of GERD and PUD. Antacid use has declined since more potent drugs requiring few daily doses have been developed. Those can obviously be obtained without a prescription. Antacids neutralize gastric acids and decrease pepsid secretion. Then we have some examples of selected antacids. So there's a bunch you can see and a bunch of different brand names for them. Antimicrobials are prescribed for the treatment of PUD to eradicate H. pylori infection. Clarithromycin, metronidazole, amoxicillin, and tetracycline are effective for eradicating H. pylori. So now we have the summary of drugs used in the treatment of gastroesophageal reflux disease, laryngopharyngeal reflux, and peptic ulcer disease. So we'll go over our warning labels since we already went over the drugs. For cimetidine and nizatidine, we want to avoid antacids within 2 hours of dose. Avoid alcohol in all of these, which if you have GERD, you really shouldn't be drinking alcohol. Any injections like famotidine should be stored in the refrigerator, and cimetidine injection needs to be stored at room temperature. For the PPIs, we should swallow whole, do not crush or chew those tablets. Take 30 minutes before a meal. Lansoprazole, esomeprazole should be taken 60 minutes before a meal. And then just some information about granules. They must be mixed within 1 to 2 tablespoons of fluid, and allow mixture to stand for 2 to 3 minutes and immediately drink entire mixture. Prokinetic drugs may cause drowsiness. Avoid alcohol. Take 15 to 30 minutes before meals. Mucosal protectants, avoid pregnancy. Take on an empty stomach. Shake suspension well. Antimicrobial combinations, swallow whole, don't crush or chew, and may decrease effectiveness of oral contraceptives.